All right, thank you for staying with Citizen TV. This is extended version of tonight. We're talking about matters UHC live from the Sunshine Hotel right here in Kericho. And the CS says I'm about to say Sunshine, but yeah, that's where I come from. It's a Sunshine Hotel. Thank you so much for hosting us here this evening. And we were talking about the Primary Healthcare Act now, Governor, and let's bring you back into this. There was an issue with the CHPs. One, how they're recruited, and two, the remuneration, because you're supposed to split this 50-50 with the national government. We know that the counties have struggled to get resources. So are we going to see a situation where the CHPs are paid the 50 from the national government, but the other 50 from the county government is not coming through, and then we see another industrial action?
Yeah, basically, like I said before, that the concept of universal healthcare is one of its own kind, not only in Africa, but across the world. And if you allow me just have a second to take you, tomorrow we are celebrating Heroes Day. What did we fight for in this independence? We fought for self-freedom. What was the self-freedom for? To have Africa move away from poverty, diseases, and ignorance. Today, 60 years down the line, we are still saddled with the heavy weight of disease. And disease has a very close nexus with poverty. Because as CS had indicated earlier, if you look at cancer, for example, and other diseases, which are terminal, it ends up depleting resources. But then the community health promoters and the universal health care will specifically speak to these issues. And that is why we are willing as county governments to realign our priorities and realign our budgets so that we are able to meet the 50% that is coming from the national government. Because for all these things to work, there must be give and take, and there must be sacrifice at some point of time. So it is not that counties really have a lot of money as it is, but it's a question of realigning your budget, that out of here, where can I reduce? For example, 10 years down the line, we have done access roads in the villages. Should we then look into the budget of roads and say, because we have been focusing on the roads, so that we don't use the roads to carry, corpses, perhaps we can use these roads for physically healthy people to transport tea to the next tea buying center. We get this money now into the health center, into the health sector. And so it's something that can really work. And remember that counties 10 years after devolution are also working hard on their own source revenue. Okay. And it is exciting that 10 years of devolution, we've seen a number of counties, including Kericho, going into digital and cashless payment of revenue. Okay. For example, I'll give you an example. In one facility that I came, there's a facility here which was doing close to 30 million in a whole year, a level 3 facility. But when we introduced cashless payment, we have pushed the revenue into close to 150 million. So it is something that is just a question of realigning our focus, taming our resources, being strict in our management, and then we'll be able to deliver on the same. Okay. Now, on terms of salary structures, I must admit at this point that this is a new thing, and we would need them to still have conversation with the national government and our ministry into what can realistically be paid, so that, because there's now a need on how we are going to harmonize the payment, so that what is paid in this county speaks also to the other county. And I speak to you today as the chairman of the Council of Governors. We have a situation where easily teacher in one county is earning this much, then in the other county, that person is earning this much. So what we are trying to do is to have a uniform payment across the county, and then now entrench it with our county public service board, which will speak into this matter in a more formal and structured manner. Okay.
Who is going to recruit the CHPs? Then any of you can answer that.
Trevor, there's a myth that people have been thinking that we sat at Afya House and settled on CHPs. That's not true. CHPs, it is globally defined, and it's a standard by World Health Organization. A community health promoter must come from the community in which they live in. Therefore, these people were identified by the county governments, right, Governor? after they have identified them, and by the way, they vote. Like in my village, where I come from, Serendu, they vote because villagers must have confidence in you as a CHP that they will be able to disclose their confidential information to you. They must have confidence in you that you can articulate their issues when necessary. So the communities will vote for their CHP. The county governments gave us names that these are the CHPs. At the national level, we took them through training, capacity build them, for them to be able to carry on the function of a CHP, which we know they are ready for it. But on the stipend, Trevor, as I had told you, the act is in place. The law is now in place. The how is what we are going to work on. But with the county governments, we are going to sign intergovernmental participatory agreements. Okay. And within those intergovernmental participatory agreements, IPAs then will define on how this money is paid. Because you can have a scenario where half of what you're supposed to get has been given to you and the other half has not been given to you. At the national level, we are planning ourselves that this should be a conditional grant. That you must be having something for your CHP for you to get this grant from us. At the national level, we are ready to go as soon as this end of this month. But now, before we do the regulations, before we agree with the county governments, then they sign for me the intergovernmental participatory agreement, then now we deliver the funds to their accounts. Okay. But the CHPs will be paid from one pot.
Okay.
Yeah.
All right.
Let's just to confirm this. A good example, we are now running the CIBs, the county integrated aggregated zones. We sat with the Ministry of Trade and Investments, Korea then, and we agree on the formula of funding. We agree that a county that has done 250 million, the national government, because it's a conditional grant, match the same. And maybe it's also good to indicate at this point, even the term community health promoters came from us, the governors. I remember we were in a meeting at Naivasha, and there was a lot of debate. What are we going to call? Is it community health volunteers? Is it community health workers? And we agreed then, when the president was sharing the meeting, that we revise the word and become community health promoters. Okay. So what I'm trying to say is that we are looking into 48 governments delivering as one. Okay. The whole story that there was a lot of fight between COG and the national government. In the Kenya Kwanza administration, we said there are no two people, one in Mount Sinai and another one in this other mountain, that are not Kenyans. Okay. The people that the county government is serving and the people served by the national government are all Kenyans. Okay. So there are no people of Nakhumicha and there are no community health promoters of Nakhumicha and community health promoters of Dr. Mutai. Okay. All these people are Kenyans that we are putting them into a job to deliver an agenda, an assignment for the 48, but one government delivery for the people of Kenya.
Okay, let's now get into the Facilities Improvement Financing Act. What is that meant to address?
Thank you, Trevor. It's called the FIF Act, Facility Improvement Fund, the Act. What this intends to achieve is to ring-fence funds from public health facilities. What I mean by ring-fencing is that we have a proper mechanism, an accountable mechanism on collection, use, and retention of funds that have been gotten from facilities. Previously, you'll go to a county facility. Funds have been collected. But where have those funds been spent? On a road somewhere. Or you go to a county, now that we're in Kericho, let me use Governor Mutai's example, that you get a hospital with a very beautiful looking gate saying this is a so-and-so hospital, Nakhumicha hospital. But once you go in, besides the beautiful gate, there are no drugs, you see? So now this Facility Improvement Fund is to ensure that there is accountability in collection, use, and retention of those funds. What we want to achieve is that they should be plowed back into providing services. And we envisage a situation, or in terms of the regulations once we come up, and some counties have even gone ahead of us, that there shall be a board, a facility board, that then shall be sitting and discussing as a management, how do we manage our funds? How do we manage the funds that we are collecting? How are we seeing through that the funds are being used effectively to provide services? That is what FIF seeks to cure.
Yeah, Governor Mutai, will this bring a bit of conflict? I know you said it's a one government approach, but will this bring conflict now when the national government is also meddling into the affairs?
Yeah,
of how
I mean, the Ministry of Health is charged with policy making.
Yeah.
Because in the devolved unit that we have in Kenya, the ministries, the national government are charged with policies. But in policies, it doesn't claw back on devolution. Because I can tell you, the day they want to step on our feet, you will be there saying that these guys are messing us up. So the point we are saying is this. For example, this FIAC, in Kericho as it is now, we already we are putting in place a number of hospitals, boards that are managing the funds that we are collecting. In fact, quite a number of hospitals, close to around 6 of them, have functional boards that are looking into the money that we are collecting and their expenditure. But what we are saying is that as the ministry provides policy direction, we know that, of course, health is a devolved function. But we are looking into a situation where there's a win-win situation. While the policies will guide us, but of course, the ultimate decision on how to run these funds really is rested on the county governments. Okay. And that is why CS was talking about the how. But I pray to God that in figuring out of how the how will look like will not be part of taking back what belongs to the county government, because that will be a little bit difficult when we reach there. But as it is now, we are very okay, and we are supporting what the ministry is doing in terms of policy direction, in terms of the discussion of these bills. I remember a month or so before these bills went to Senate, we had a meeting with her team, and we were able to weigh in as COG and be able to panel bid before it goes to that direction. Okay.
Trevor, let me clarify something. These bills, now acts, the 4 of them, 2 originated from the National Assembly, 2 originated from the Senate. The ones that originated from the Senate have everything to do with county governments. That's the Primary Health Act and the FIF Act. By the way, the regulations for FIF will not be done by us, because they're the ones who know. The regulations will be done by the county governments. Okay. So that is their responsibility. You better start saying, Governor, how you will go about it. Okay. My team is available to guide so that we come up with proper regulations. Right. And because we want to retain we want them to retain their mandate, that they have to define themselves how they are going to do it. While the regulations for the Social Health Act and the Digital Health Act will come from the national government.
Okay. And finally, the Digital Health Act. What is this meant to achieve? I know you said that the regulations will be done, and then I'll open the floor for questions, and they'll all pose to you most likely.
The Digital Health Act seeks to leverage on technology in providing healthcare. Through this Digital Health Act, we want to ensure that we collect real-time data. And this real-time data then can be used for decision-making for the betterment of the healthcare of the country. For example, at the moment, you'll find that at KEMSA, we are out of stock of some basic drugs. Why are we out of stock? It's because of the process that is used in determining the quantities that need to be bought for those essential supplies. Why? Because we have either inaccurate data, or we have old, obsolete data, or we have data that has just been not collected properly. So the digital health then assists us to collect data and ensure that we use it for decision making. The other thing that the Digital Health Act is going to assist us is to ensure that there's proper storage of data and there's sharing across facilities. That data for a patient can be moved from a lower level facility to a higher level facility. Trevor, you know, many Kenyans have if they're from the rural, like myself, you know, I'm a village girl, there's the quota exercise book that when you go to a dispensary, you are given quota of an exercise book where your names are written, your details. So that when you go for health service next time, you have to go with that quota exercise book. You can lose it, or sometimes it's written in pencil, it gets erased, you see? So now, and if you are referred, you are expected to go with that quota of a book from one facility to the other. So what we have done now is that the data is collected digitally, it is kept. Then it is shared, that people are given access, those who need to provide service to you. If you have to move from a dispensary to a level 3 facility, you will find your data there. And we did a demonstration at Kapkatet. I remember very well. From a household, and we were able to trace how that patient or how that household was moving through the levels of service. Trevor, again, the other thing that this digital health bill is going to give us is confidentiality and privacy of that it defines who is it that can access patient data and at what level. Okay. It ultimately, it gives you as an individual, the owner of the data, the right to give somebody access to your data. You see, like now, if you want to withdraw money to your account, I do not know if you have mobile banking. I do have. If I want to do a transaction, for example, a bank will send me an OTP number. That OTP number, I place it in. Then I'm authorizing a transaction to happen. So somebody will have their data. Once that data needs to be accessed at a health facility, there will be a prompt. So that then you are in control of your data. Yeah. Then you can give that person access to your data. Okay. Yes.
So this will be based on also the mobile phone penetration in different places.
Exactly.
Okay.
Actually, one of the things that we have given our community health promoters is a smartphone.
Okay.
So that then data is collected real time, and that smartphone is connected to the levels of service.
Okay.
And besides that at the national level, we are able also to monitor how the community health promoters are doing their work.
Okay.
So we shall be watching.
All right. Yeah. Governor Mutai, do you see the challenge with this? Because there are certain areas in certain counties that don't even have the infrastructural capability.
Yeah, yeah, I agree. But just to weigh in on how this will revolutionize the healthcare network completely. In Kericho already, we have worked in digitalizing 11 hospitals. We are done completely with them. And the beautiful thing is that for the community health promoter, once sorting a family, and we need to make Kenyans understand that community health promoters are not just, they're not just to come and look for the sick person. So when you come to our home, the family of Nakhumicha, you check the child if he has fever, and also check on Nakhumicha, his pressure, his heartbeat, his eyes, if they are okay. Then with these details of the family, with the catches that have been given, once they key in, it hits to the next health center. So when you move in there, you won't need to queue because already it's been determined where you're supposed to go next. What is going to happen is that, first of all, it will save on time and also provide timely response to the patient's management. I look at it that the account is as it is, which coverage and network has not been in that place. But you must also accept that in the absence of even structured networks, we have nowadays portable network communications. When you go somewhere, you can carry some modem there or something like that. And I think for our colleagues in COG, because this is a very important component, would be moving to think outside the box on how we are going to, when as we wait for the national government to provide networks and service providers, that we look at ways on how we can help them. But I admit at this point of time, yes, indeed, we have far remote areas that probably this may be a challenge, but I know over time this will be, we'll overcome this.
Okay. Trevor, this government, we are delivering as one. We have the Ministry of Information, Communication and Digital Economy. This ministry has been given the responsibility of ensuring that it lays infrastructure, ICT infrastructure in several places. A few months ago, I accompanied my colleague Owalo to launch Wi-Fi's. And many Kenyans on Twitter were asking, what does health have to do with a public Wi-Fi? I knew I'm doing it because eventually my health facilities are going to be connected to that Wi-Fi. So the Ministry of ICT has been given a task to ensure that there is a Wi-Fi in each and every ward, a marketplace, or where there's a public facility. They're expected to provide the Wi-Fi. So they are laying the infrastructure that then us as a ministry, we come and plug onto that Wi-Fi. Okay. The PCN that we have established here, the Ministry of ICT came and laid the infrastructure. The ministry, working together with partners, we brought the equipment that is required for connectivity to happen. So I want to believe that even those far-flanked areas, there's a mechanism onto how we are going to do it. Now, digitization of a primary care network, it is going to be progressive. It's not something that we'll achieve in one day. You know, we shall do it progressively until at the end of some good time, then all facilities are able to be networked.
All right.
Yeah.
One request to the seers. We have counties with very small budgets. You know, you have a county with a budget of 3 billion a year. So they are torn in between how to pay and what to do. So in terms of the network coverage, you know, as we go through this, I would also improve upon Owalo and maybe herself to keep focus maybe on those areas with little budgetary allocations, and they may not be able to remove their own, and allocate their own county government money to meet some of these things. Okay. And I know this will go a long way also supporting those county governments.
All right. Now that the 4 acts have been explained, I'm going to open the floor for questions, but that's coming right after this short break. We're coming to you live from the Sunshine Hotel right here in Kericho. The host for Mashujaa, the county in general, and the host governor is also here. Now we'll come with the questions in just a bit, but don't go too far.